Good afternoon, everyone. My PhD thesis title is about the new insights on the prognosis of pancreatic ductal adenocarcinomas. My name is Lőrinc Ulmann. I'm a surgical resident here at Semmelweis University and a PhD student. My supervisor is Ákos Szűcs, and my SMS is Mahmoud Obaiddat. My vision is to be able to combine research and knowledge in the surgical treatment of pancreatic cancer. And my mission is to research how the different pancreatic cancer mutations lead to a different prognosis. I have two specific goals with two specific projects, which I have both started in 2023, and I'll start with the first one. First of all, my first project is about investigating the prognostic relevance of micro-RNA analysis of pancreatic ductal adenocarcinomas. In order to introduce this topic, PDAC, or pancreatic ductal adenocarcinoma, is one of the worst prognostic cancers in the world with a 5-year survival rate of around 7%. So, what do we tell the patients? Is this only a homologous disease? Well, one possible solution for this could be microRNA analysis. MicroRNAs are a group of nucleotides which could either act as oncogenic microRNAs or tumor suppressor microRNAs and act in the development of pancreatic cancer. Therefore, our aim is to investigate the prognostic relevance of these biomarkers in the analysis of PDACs. Our clinical question is, could these nucleotides and their analysis give precise information about the prognostic of these patients? Our population is patients diagnosed with PDACs. Our prognostic factor would be the high and the low expression of these microRNAs, and our outcome will be measured in overall and disease-free survival. We're hypothesizing that the change in the microRNA levels in patients diagnosed with PDACs is actually associated with a worse prognosis. We have conducted our systematic search in 3 databases, and you can see our search key here. You can see our outlined key articles, and you can see that we have the same population, the same prognostic factor in terms of the different microRNA levels, and the outcomes were all measured the same way. You can see our flowchart of selection here. We have started out with 11,000 articles without the citation chaser and 3,000 from the citation chaser, and then eventually ended up with 148 eligible articles. We unfortunately do not have our statistics done yet, but we did conduct our search and did get our data. But our ongoing analysis, therefore, is in terms of overall and disease-free survival. And we do have some preliminary results in terms of the overall survival. You can see our results here in terms of the preliminary results. After the line of no effect, there will be a greater survival with a lower expression of the microRNAs, whereas below it, there's a greater survival of the patients with a higher expression of the microRNAs. You can see that there are many types of hazard ratios measured here, but we will investigate this further when we have the statistics done. The strength of our project is that we have analyzed a lot of microRNAs, and they do show an association with survival data. But our limitations is that we still need the final data in order to compare the same microRNAs in terms of the groups, and we do have heterogeneous population since there are different therapeutical methods and different therapeutical groups included. You can see our progress here. We have all extracted the data, done the risk of bias, and we're still waiting for the figures and tables. Our second project is about investigating the effect of different neoadjuvant therapies on the prognosis of borderline resectable PDACs. We have started this project in September 2024. In order to introduce this topic, the actual treatment of pancreatic cancer is surgery alone. However, only 15 to 20% of these cases are actually resectable. Without resection, the 5-year survival rate is around 7%, but if it is resected, then it can increase up until 30%. In the borderline resectable group, if it's not resected, then the overall survival will lead to 17 to 29 months, whereas if it's resected, there will be an increase from 24 to 33 months. Therefore, Our aim with this project is to investigate the effect of different types of neoadjuvant therapies on the prognosis of borderline resectable PDACs. Our clinical question, which we're trying to answer, is therefore, what is the best type of neoadjuvant therapy for borderline resectable PDACs? Our patients, our population is our patients with borderline resectable PDACs who are actually undergoing neoadjuvant therapy. And we're including the different types of neoadjuvant therapy groups, such as chemotherapy alone, chemotherapy combined with radiotherapy, and or minimal invasive radiological interventions. Our outcomes will be measured in overall disease-free survival and the percent of operability. We're hypothesizing that chemotherapy alone is safe and more effective in the treatment of borderline resectable PDACs than any other neoadjuvant therapy method. Our clinical implication is that is in terms of safety and efficacy, survival, and recurrence rate. You can see our progress here. We have determined that the topic is feasible. And as a summary, here are our 2 projects, which we're trying to submit this year. And I'd like to end my presentation with a quote from John D. Rockefeller: "If you want to succeed, you should strike out new paths rather than travel the burned paths of the accepted success." Thank you.
Thank you, Lőrinc, for your great presentation. Until the audience is thinking, I am curious, do you know which type of microRNA is the most common one?
I do. It's actually micro-RNA 21 and micro-RNA 200. These are the more common ones, and if they have an increased level, then the prognostic should be worse. But we're still waiting for the data.
Thank you.
And how much is it depends on the methodology they use to determine the microRNA?
You mean the methodology in terms of measuring the level of the microRNAs? They actually have 2 types of methods because since we're including studies from 2008 up until 2023, and actually the method is around the same, but they use more recent technologies in order to make it cheaper and faster, but the results are actually measured the same way.
Mm-hmm. And if you analyze the data separately, then is there any difference between them? I mean, the 2 types.
Oh, you mean the levels? You mean the
Uh-huh.
levels? No, not really. So, so they are actually comparable in terms of these groups.
Mm-hmm.